Good evening and thank you for joining us today for this important webinar on postpartum hemorrhage. I, Amit Saxena, along with my teammate, Dr. Deepika Chabra from Medical Services Department of Jagsonpal Pharmaceuticals, would like to extend a warm welcome to all those who have joined us to this AOGD Delhi PG Forum discussion on postpartum hemorrhage by postgraduates of Kasturba Hospital, Delhi with academic partner Jagsonpal Pharmaceuticals Ltd, the makers of CycloReg 10 mg CR tablet, Divatrone syrup and Divatrone, our newly launched dydrogesterone. We thank you for this opportunity to connect with you today through this webinar and proud to present Divatrone 10 mg tablets, fully indigenized micronized dydrogesterone, the only brand having 36 months of shelf life. Jagsonpal would like to express gratitude and extends warm welcome to experts and attendees. The Facebook link for today's webinar has already posted on the chat box, and you may share this link on your Facebook or WhatsApp accounts. We now request Coordinator Delhi PG Forum, AOGD PG Forum, Dr. Sunita Malik Madam, and Co-Coordinator Delhi PG Forum, Dr. Shivani Agarwal Madam, to kindly initiate this proceedings.
Thank you, Amit, for the kind introduction. And good evening, friends, colleagues, and of course, my dear students. We are again present with the youngsters, on Delhi PG Forum. And of course, the new session and new year, and of course, the new team of AOGD under Dr. Amita, Suneja, Dr. Abha Sharma, Dr. Radhika. So the three of them as vice president, and secretary, they have taken over. And Dr. Seema Prakash is our coordinator from AOGD side. So the team is from UCMS and GTB Hospital. And Dr. Amita is the president. She is not able to join today due to some other commitment. So we have Dr. Abha Sharma here. She is senior specialist. She's vice president of AOGD, medical superintendent of GTB Hospital, and associated UCMS, vice president of AOGD in 2023-24 now currently, and she was secretary of AOGD in 2017 and 18, and they really had a very good program at that time, and they won the best trophy also during their tenure under her secretaryship. She was also treasurer of AOGD and NASG. She's got many publications in national and international journals, and her area of interest is in Mullerian anomaly and VVF. I welcome Dr. Abha Sharma to say a few words about today's topic, PPH, which is a really, once it's there, it's a nightmarish experience, and everybody should be well versed with how to diagnose, how to deal with it. The very important topic. Okay, Dr. Abha, you would like to say a few words?
Thank you for the kind introduction. And at the outset, I would like to thank Dr. Sunita and Dr. Shivani for continuing to be the coordinator of this PG forum. As you are all aware, the PG Forum is a very important program of AOGD, preparing the young minds, our young obstetricians, for not only passing the exam, that is also important, but also in managing different difficult cases and to be aware of that. So today's topic, postpartum hemorrhage, is definitely one of the most important topics for postgraduates. And as you know, PPH is definitely the biggest nightmare of the obstetricians. One moment you are happy having delivered a child, and the next moment your patient starts pouring, increasing the obstetrician's blood pressure to this thing. So in today's case presentation, I believe we are going to discuss what are the risk factors and how to manage this dire emergency. And I'm sure my postgraduates will greatly benefit from the discussions. And thank you and welcome to Dr. Ajmani and
Thank you, Dr. Abha.
yes.
So this is Radhika. She's also busy with the executive committee meeting. She is again Dr. Seema Prakash. Next, and she's consultant Obs and Gynae UCMS and GTB Hospital and fellow ICOG. And she's worked in medical education committee of FOXI as a member. And she's also has many contributions in Obs and Gynae books, recipient of Exemplary Service Award DMA 2020, and has been member of many societies of FOXI, AOGD over the years. We welcome Seema Prakash. She is the coordinator from AOGD site. And next to chair today's session, we have Dr. Sangita Nangia Ajmani. She is a senior specialist and medical superintendent of Kasturba Hospital, New Delhi. She is a recognized supervisor for the postgraduates of University of Delhi, WHO fellow in gynae endoscopy, and of course, many publications in national and international. Her field of interest is gynae endoscopy and reproductive endocrinology. So today her PGs are going to present the case. So I would like Dr. Sangita to say a few introductory words to her students.
Thanks, Dr. Sunita, and thanks, Dr. Deepika and Dr. Shivani for inviting to this forum. And I feel if PPH is such an important, vital area of obstetrics, that if one grasps the management of PPH, 80% of obstetrics is covered in that. And all of us have undergone this nightmare, which Dr. Abha mentioned. One moment we deliver and we are happy that we've got a live baby, crying baby, and another moment the mother is pouring. So this management is the real exam of obstetrics, which our PGs learn to grasp and become a good obstetrician. So once we achieve 0 deaths from PPH, then we have done something, because at present it is accounting for 24% of the maternal mortality, which is very sad. And PPH management involves quick response, skilled management, availability of support system, and patience. And most important is not to create panic. We have to create alarm, but not panic ourselves. So we have to ask for help. We have to do everything possible, as we'll discuss in the class, but not to create panic in our own mind, so that we manage PPH in a rational way and end up saving a life. So once we save a mother, we save a family. So I wish best wishes to the students. I hope you can present your matter well, so that take-home messages are being conveyed to the postgraduate students. All the best.
Thank you, Dr. Sangita. So now the other expert chairperson for today's class is Professor Achla Batra. She is National President of NACHI all over India and President NACHI Delhi. She was President of AOGD also. She's got so many awards and she's been really working hard for the public health, Anemia Mukt Bharat, and and so many guidelines she's contributed to on WHO pocketbook also. And her area of interest is gynae urology, urogynecology, and of course, high-risk pregnancy and critical care. Dr. Achla will be joining a little late, and she'll be giving her expert comments at the end of today's class. Now I go over to today's moderators. We have Dr. Bindu Singh. She is consultant gynecologist in Kasturba Hospital with 30 years experience in obs and gynae. Special interest is high-risk pregnancy, adolescent medicine, and laparoscopy. The other moderator for today's class is Dr. Swati Agarwal. She's professor in Department of Obs and Gynae, Lady Hardinge Medical College and Sucheta Kripalani Hospital. She's Joint Secretary of Nachi Delhi and NachiCon World Congress 2022. Very well conducted workshop. At present, she's chairperson of AOGD Endoscopy Committee for 2 years, and she's got many awards in her name. And at present, she's also busy in, making our women in anemia mukt, at least in Delhi and NCR. So well done. You are doing very well. The residents for today are Disha and Shreshtha Agrawal from postgraduates of Kasturba Hospital. So over to you, Bindu and Swati. You can now start your class today. Yes, please.
Thank you for the kind introduction, ma'am. Dr. Bindu, would you like to start?
Yes. Thank you, Dr. Sunita, and thank you, Dr. Shivani. My regards to my senior and my good wishes to my juniors, Dr. Disha and Dr. Shreshtha Agarwal. We are presenting a case on postpartum hemorrhage. It is why I just give a small introduction. Why do we need to focus on BPH so much? As per World Bank data, India has a maternal mortality ratio of 145 per 100,000 live births in 2017. But our goal in 2030 is to reduce it to more than half, that is around 70 per 100,000 live births. So to do that, we really have to work on PPH, and PPH affects 2 to 4% of vaginal deliveries and 6% of cesarean section deliveries. So looking at the data, we can see that PPH is a major killer. As per WHO sheet, it is a major as well as a very rapid killer. So we really have to tackle the problem. Here we can see that as per WHO, the maternal mortality ratio 23% is, this is the major part which is attributed to postpartum hemorrhage. So that's why we are discussing a case today on postpartum hemorrhage, and I think PGs will be benefited with it. Why this golden hour? Every minute of the golden hour counts, because if we manage the PPH well in the first hour, we might save the patient. So every minute of the golden hour counts. Now I switch over to Dr. Disha and Shreshtha. They can share the slides. Disha.
My patient, 35 years old, brand multipara, that is gravidas 7, para 5, live 5, live issue 5, abortion 1, at 39 weeks plus 2 days of gestation, came at casualty with labor pains. Her LLP was 15th May 2022 with EDD of 22 Feb 2023. In history of presenting illness, patient complains of pain at lower abdomen since last 1 day, which was gradually progressive in nature and increasing in frequency, intensity, and duration. The pain was cramp-like, occurring every 5 to 10 minutes, radiating to thighs and lower backs. The fetal movements were perceived adequately. There was no history of leaking for vagina or foul-smelling discharge, no history of pedal edema, headache, or blurring of vision. There was no history of easy fatigability or palpitations, no history of itching in palms and soles, no history of gum bleeding, epistaxis, or any worm infestation. In her obstetric history, my patient first and second childbirth was at home, which was uneventful. The third childbirth and fourth childbirth was 6 years back and 4 years back, which were full-term normal delivery at government hospital, which were also uneventful. The last childbirth was 1.5 years back, which was a full-term normal vaginal delivery at a government hospital of a 3 kg male child. There was a history of heavy bleeding soon after delivery and history of 1 unit blood transfusion after delivery. Also, there was a history of 1 spontaneous abortion 7.5 years back, which was not followed by DNC. The present pregnancy conceived spontaneously. The first trimester history was uneventful. My patient only had single visit in first trimester. She took her folic acid tablets regularly. Early scan was corresponding to gestational age. Her second trimester history was also uneventful with normal anomaly scan. A single booster dose of tetanus was given. She took her iron and calcium tablets regularly. My patient had no antenatal visits in third trimester, but as per patient, her fetal movements were adequate. Intake of iron calcium tablets were irregular, and there was no history of bleeding, leaking, pain abdomen, headache, fatiguability, or any palpitations. My patient's menstrual history was regular. There was nothing significant in past history and family history. My patient had no history of any contraceptive usage. In drug history, my patient was not on any chronic drug intake. She was only taking iron and calcium tablets. In personal history, my patient was a homemaker with a normal sleep cycle, with regular bowel bladder habits, vegetarian by diet, with no history of any drug abuse. The socioeconomic status is of lower class. In general physical examination, my patient had a BMI of 22.4 in the first trimester. The vitals were normal. She had a mild pallor present, but there was no icterus, no clubbing, no cyanosis, or any pedal edema. In systemic examination, no abnormality was detected in respiratory system and cardiovascular system. Per abdomen examination shows that on inspection, all the quadrants were moving equally with respiration, abdomen distended, linear nigra and stria gravidarum was present, umbilicus central and everted, no scars or dilated with seal, and all hernial sites were intact. On palpation, there was no organomegaly. The fundal height was 34 weeks with flanks full. Presentation was cephalic. The patient was having 2 uterine contractions in 10 minutes, each lasting for around 15 seconds. On auscultation, FHS was heard regular, 140 beats per minute on the left spinoumbilical line. On local examination, external genitalia was normal with no leaking or bleeding. On pervaginal examination, cervix was soft and wet position, 4 centimeter dilated, 50% effaced, bag of membranes were present, vertex was at -3 station, and pelvis was adequate. Her ANC investigations were of 16th October, which showed hemoglobin 9.1 gram per deciliter and peripheral smear report of microcytic hypochromic anemia. Rest of the parameters were normal. Her latest ultrasound report was of 13th Feb, showing a single live intrauterine cephalic fetus with estimated fetal weight of 3.32 kgs, showing parameters of 39 weeks. The center was frontoanterior and Lyca was adequate. At the time of admission, I sent CBC report in which hemoglobin came as 8.9 gram per deciliter, platelet came as 1.86 per millimeter cube. BTCT was within normal range, and BGCM was kept and sent for PCV cross matching. My patient was left for spontaneous progression in labor room. FHS monitoring was done every 30 minutes. After 2 hours, when my patient was having good contractions, repeat PV was done. The os was 6 to 7 centimeter dilated, 70 to 80% effaced, and vertex reached at -1 station. SRM occurred and clear like a drain. The blood group availability was also confirmed at the blood bank, and 2 units PCV were arranged for my patient. At 5:30 p.m., that is after half an hour, it was noted that patient started bearing down, crowning was seen. Patient immediately shifted to delivery table for delivery, and after giving perineal support, a baby delivered vertex followed by rest of the body. Injection oxytocin 10 units intramuscularly given immediately, cord clamped and cut after 1 minute. After 3 minutes, placenta was delivered by controlled cord traction, and on inspection, a complete placenta was delivered with complete membranes.
After delivery of placenta, my patient was having excessive continuous vaginal bleeding along with passage of clots, and uterus was relaxed. Soon, immediately call for help was made. Bladder was catheterized. Uterine fundal massage was started. 2 widebore IV cannula were inserted through 1 cannula 20 units of oxytocin with 1 unit of 500 ml of RL was infusion at the rate of 60 drops per minute. From another IV cannula, blood sample was drawn and it was sent to lab for investigation. 500 ml of RL IV fluid was rushed from another cannula. Oxygen administration was started through the nasal prongs. Injection 1 gram Tranexa was given IV slowly over 10 minutes. As my patient was still bleeding, injection Methergine 0.2 milligram IM was given. Visual estimation of blood loss was made. It was around 750 ml at that time. Vitals were monitored. It was BP 100/68. Pulse rate was 94 per minute. Respiratory rate was 18 per minute. Saturation was maintained at 99% and urine output was 150 ml at that time. My patient was continuously bleeding. So injection carboprost 0.25 milligram IM was given. Along with that, tab misoprostol 800 microgram was kept per rectally. Cervix and vagina was explored quickly to see if any laceration or tear is present. As there was no tear, blood loss estimation at that time was 1 liter. Vitals at the time was 90/60. BP was 90/62. Heart rate was 110 per minute. As patient was continuously bleeding, patient was shifted to OT immediately, maintaining bimanual uterine compression. Informed high-risk consent was taken from relatives. As soon as patient reached OT, 1 unit of blood transfusion was started. Vitals at that time was BP 82/54. Pulse rate was 120. Respiratory rate was 24 per minute. Urine output was 150 ml and saturation was maintained at 99%. Inside the OT, lower genital tract exploration was done under suitable anesthesia. Complete exploration of paraurethral region, perineum, cervix, vagina, and uterus was done. There was no tear or laceration found. Uterine cavity was intact. A few blood clots was removed from uterine cavity. My patient was still bleeding. So uterine balloon tamponade was done using Bakri balloon under antibiotic coverage. After insertion of balloon tamponade, vitals were BP 94/60. Pulse rate was 110. Respiratory rate was 20 per minute. Another second whack of Paxil volume infusion was started at that time. After insertion of balloon, investigations were sent for complete blood count, PT INR, and serum electrolytes.
Summarize your case and we'll go on with that.
Patient was monitored after insertion of balloon. Vaginal bleeding was significantly decreased. Patient was monitored inside the OT for 30 minutes. Vitals were stable and vaginal bleeding was decreased. Patient was shifted in recovery room and was monitored there continuously for at least 4 hours. Meanwhile, investigations after balloon insertion report came. Hemoglobin was 6.1 gram per deciliter. Hematocrit was 17.9%. PTINR was 1.3 and serum electrolytes were within normal limits. After
which balloon did you use?
Ma'am, Bakri balloon was used for insertion.
You inserted it in the OT?
Yes, ma'am. Bakri balloon was
What
inserted.
was the procedure? How did you insert it?
Ma'am, Bakri balloon kit was opened. Vaginal.
Do you have any slides to show the pictures?
For insertion of balloon, posterior vaginal wall was retracted using Sims speculum. Anterior lip of cervix was pulled by a sponge holder. Tip of Bakri balloon was pulled with sponge holding forceps and it was inserted into the uterine cavity. Then I kept all the instruments were removed. I kept my hand at the level of cervix to support the Bakri balloon. Inflation was started using normal saline. Around 450 ml of saline was inflated inside the balloon. Then vaginal bleeding was significantly decreased.
You do the tamponade test for this?
Yes, ma'am. Ma'am, tamponade test is positive if is said positive if vaginal bleeding stops. significantly decreased.
How much fluid did you instill in that?
Ma'am, around 450 ml of normal saline was instilled.
And
Then
then
vaginal bleeding was significantly decreased at that time, and vitals were checked at that time after insertion of balloon.
So very important point here I want to make, Disha, you very rightly said that you are supposed to keep your fingers at the level of the cervix. Otherwise, practically what happens when we are filling this balloon, that balloon keeps on slipping out. So it keeps on popping off. So practically, for beginners who have never used a balloon, it's very important, this point, that you need to keep your fingers there, or sometimes you might need 2 sponge holders, one at the anterior lip and one at the posterior lip, and keep them together to kind of occlude the os, so that as the balloon is getting filled, it doesn't keep coming off the cervix. So that's very important.
After inflating balloon and as bleeding has decreased, I removed my hand and I placed the vaginal packing so that balloon maintains its position inside the uterus.
Then how did you monitor after placement of your catheter?
Ma'am, for 30 minutes, patient was kept inside the OT only and was monitored continuously for BP, pulse rate, vaginal bleeding, and urine output. After 30 minutes, as patient was stable, patient was shifted in recovery room. Over there, patient was kept under monitor continuously for 4 hours, and patient was watched for urine output, bleeding, and BP, pulse rate, saturation. After 4 hours, patient was shifted in post-op ward. Over there, patient was monitored for vitals, bleeding, and urine output on hourly basis for at least 12 to 14 hours. Next day morning, 9 a.m., my patient's
the patient was stable for these 12 hours?
Yes, ma'am. Vitals were stable in this hours, and urine output in morning urine output was around 1,500 ml, and the saturation was 99%. Morning, ma'am, BP was 110/70, pulse rate was 88. Uterus was on per abdomen examination. Uterus was contracted. Vaginal bleeding has stopped. There was no bleeding coming out from the drainage port. So deflation of balloon was started since then. For deflation, I deflated 100 ml of saline from the balloon, and I waited for 1 hour. There was no further vaginal bleeding coming out. Uterus was maintaining its tone. It was contracted. Vitals were stable. So after 1 hour, I again deflated 100 ml of solution. This way, on hourly basis, I have deflated 100 ml from balloon, and vitals and urine output and uterine tone along with vaginal bleeding was monitored. After complete deflation.
What additional thing, Disha, you would monitor if you were using a condom balloon in place of a battery balloon?
Fundal, I will monitor fundal light because it doesn't have any drainage port. So
that's very important message. With a condom, if the bleeding is occurring above the level of the condom and it's collecting, then the vaginal bleeding might not be there, but the fundal height will increase. So you need to mark that fundal height on the abdomen. So that's very, very important, because in many in many hospitals, Bakri balloon may not be available, and there is no drainage port in the condom catheter. So that's an important point. Okay.
After
did you give anything else with this? I mean, did you repeat tranexamic acid? Or
yes, ma'am. After complete deflation of balloon, injection Trenexa 1 gram IV slowly was given.
Okay.
After complete deflation, deflated balloon was kept.
IV slowly means how slowly?
Ma'am, around 10 to 20 minutes. We have to give this slowly, around 10 to 20 minutes.
Or you can give by infusion also.
Ma'am, after complete deflation, balloon was kept inside the uterine cavity for at least 30 minutes. As there was no further vaginal bleeding, uterus was well contracted, vitals were stable, deflated balloon was removed, and patient was
again monitored.
What else would you do to keep the uterus contracted? Once you put the balloon, is there anything else that you would give her?
Ma'am, we should continue oxytocin uterotonics to be continued meanwhile. Balloon is
that's very important. You need to continue the uterotonics while the balloon is in situ, otherwise the uterus may relax again. And even after removal, you need to continue your uterotonics for some time. It's not that you remove the balloon and you stop everything. So continue your uterotonics for some time.
Next morning, again, blood investigations were sent. And her HB was 7.8 grams per deciliter, hematocrit was 30.1, PTNR report was 1.2, serum bill was 1.4, liver enzymes were 3438 SUT, SGPT, serum creat was 0.86, blood urea was 22, serum electrolytes were within normal limits, and serum fibrinogen level was 300 milligram per deciliter.
So in this 12 hours, how much fluid and how much blood did you give, Disha?
Ma'am, in my patient, I have given around 2 liters of crystalloids were infused, 2 Pexel volume was infused.
And what was the urine output?
Ma'am, urine output in morning, it was 1,500 ml.
How do you tell if your consultant is asking you on the morning rounds that, Disha, tell me what is the urine output of this patient? How would you tell the urine output? How would you inform the urine output to your consultant?
Ma'am, urine output is adequate. Ma'am,
How do
in
you say
last
it?
20,
How much it should be?
ma'am, my patient's urine output in last 4 hours is 100 ml, is more than 100 ml.
So that is more important, you know, that you tell what is the output over the last 2 hours or 4 hours. When you say 1000 ml, you know, that 1000 ml could have been emptied at 9 o'clock in the night. After that, the patient has gone into anuria and that 1000 ml is still in the bag. So whenever you are informing about the urine output, you give a total overall urine output, 24 hours, you can give the input and output. But what is more important to have a look at the output in over the last 2 to 4 hours, that would give you a idea of the current status of the patient, and it should be at least more than 30 ml per hour. That is the minimum.
More than 30 ml per hour.
Case summary. My patient was grand multipara, parity 6, live 6, abortion 1. Day 1 of vaginal delivery. She delivered 3.2 kg female baby with good Apgar score. With primary PPH with blood loss around more than 1000 ml. And she was managed by uterotonics, tranexamic acid, and tamponade with Bakri balloon.
What is primary PPH, Disha? You said it's primary PPH. What is primary?
Ma'am, if blood loss after vaginal delivery, if more than 500 ml of blood loss after vaginal delivery or more than 1000 ml of blood loss after cesarean section in first 24 hours of delivery is known as primary PPH.
Is there any other kind of PPH?
Yes, ma'am, secondary PPH.
Okay, what is that?
Ma'am, if a patient is having abnormal vaginal bleeding, abnormal or excessive vaginal bleeding, after completion of 24 hours up till 12 weeks POG, up till 12 weeks PNC. Up till 12 weeks.
Most common cause of secondary PPH?
Ma'am, sepsis, infection, uterine infection, and retained tissue.
Most common cause of secondary.
Retained tissue. Ma'am,
You mean placenta.
Dr. Bindu, you can continue. Dr. Sangita, you want to say something?
I wanted to tell her that they were lucky that this grand multipara patient managed conservatively, and normally the impulse is to do away with hysterectomy. So obstetric hysterectomy is most common on this grand multipara patients, but she was managed with Bakri balloon. But
luckily we have this.
Yeah, and since she was grand multi, so what all precautions you took for her delivery, that I wanted to make clear, that what all you anticipate and how you prepare for such a delivery.
Our patient was a grand multipara and already had a history of PPH in last childbirth. So we were very vigilant since the admission of the since start of the at the time of the admission of the patient. We informed the senior obstetrician about the admission and simulate all the team at the labor room about this case. We sent the important investigations and also arranged 2-unit PCV beforehand. The PPH card was kept ready at the time of delivery, and An active management was followed at the time of third stage of labor.
What does the card contains? Your
The
management.
PPH card contained 4 IV bore cannulas, a Foley's catheter, and all the injectable uretonics as well as misoprostol. And it also contained IV tranexamic acid and all the crystalloids and colloids. PPH card also contains all the instruments that could be needed for the genital tract exploration. There is a risk classification scheme which was given by
Your patient was a high risk or moderate risk?
Patient line in medium risk now.
How do you, what are the categories of this? How do you classify the risk?
The risk classification scheme which was given by California Maternal Quality Care categorized patient into low risk, medium risk, and high risk. Low risk patient is a singleton pregnancy, less than 4 previous deliveries, unscarred uterus with no history of PPH and no bleeding disorders. So universally, we can say that all pregnant women are at risk of PPH. In medium risk, there is a prior cesarean or uterine surgery, grand multipara, multiple gestation, history of PPH in previous pregnancy, large uterine fibroids, or chorioamnionitis. And in high risk category, there is placenta previa, known case of bleeding disorder, bleeding at the time of admission, hematocrit value less than 30%, or placenta accreta in fetal pulpita.
There are various definitions given by different.
Yes, ma'am. Different agencies.
So can you define those? Yes.
WHO defines PPH when the blood loss is more than 500 ml in vaginal delivery and more than 1000 ml in cesarean section. Whereas ACOG defines PPH as a cumulative blood loss of more than 1000 ml regardless of route of delivery, or any blood loss which was associated with signs and symptoms of hypovolemia. The RCOG divides PPH into minor and major PPH. When there is a blood loss of 500 to 1000 ml, it is minor PPH, and more than 1000 ml is major PPH.
What were the high-risk factors for PPH in your patient, Shreshtha?
Ma'am, our patient was a grand multipara, and
Okay.
also she had a history of PPH in last childbirth. My patient was having moderate anemia, which was an aggravating factor for the PPH.
Is it a high-risk factor for PPH also? Anemia, is it a high-risk factor for PPH as well?
Ma'am, if the hematocrit value drops less than 30%, then it comes under high-risk factor.
Yes. Why? What is the reason for anemics to be at high risk for having atonic PPH?
Even ma'am, less blood loss. Ma'am, even a minute amount of blood loss will result in major.
That is that they will not be able to tolerate the blood loss. But are they more predisposed to PPH?
No, they are not predisposed. Just
they are actually, there are many studies that say that anemics are predisposed because of the impaired myometrial contractility in these patients, because of the lower hemoglobin and the lower oxygenation of the myometrial tissues. There have been studies where they found that women with a hemoglobin of less than 10 gram% have higher propensity to have PPH. So it has something to do with the myometrial contractility. They tolerate the blood loss poorly, as well as they are, predisposed to PPH. One more thing, what about the labor progression in your patient? Was it a precipitate labor?
Ma'am, precipitate labor is defined when the expulsion of fetus is within 3 hours from the start of the good contractions. As a patient arrived in casualty when she already had a 4 centimeter dilatation, so we cannot comment that whether the patient had precipitate labor or not.
But she came to you at 3 o'clock at 4 centimeters and she delivered at 5.
Delivered at 5:13.
So we can say that she was precipitate labor.
But she might have uterine contractions started at home much before.
Yeah, that she might not have, classically fit into the definition of precipitate labor. But yes, this is definitely faster than what you would expect. From 6 and 7 centimeters within half an hour she delivered. Yes, so this labor was also, and this kind of also predisposes her to develop PPH. Right? All right. So,
what are the types of PPH you were saying?
We have already discussed.
We discussed that.
Yeah, we have discussed that primary and secondary PPH. So what algorithm, is there an algorithm that we follow for the management of PPH?
Yes, ma'am. Chandraharan has given an algorithm for the management of PPH, which is spelled as hemostasis, in which H stands for health, A stands for assessment and resuscitation, E stands for establishing etiology and ensuring availability of blood, M stands for massage of the uterus, O stands for oxytocin. In stasis, S stands for shifting the patient to operating room, T stands for tamponade, A stands for applying compression sutures, S stands for systematic pelvic devascularization, I stands for interventional radiology, and S stands for subtotal or total abdominal misplacement.
I think before we come to
case-
that, we have missed one thing, that you did not tell us about the active management of third stage of labor. So this patient, we need to do active management of third stage of labor. So what are the components of active
Yes,
management?
ma'am. There are 4 components in the active management of third stage of labor. The foremost important component is the administration of uterotonics just immediately after the birth. That is, and the mode drug of choice is oxytocin. Then there is the second component is the delayed cord clamping that should be done after 1 to 3 minutes. The third component is the delivery of placenta by the controlled cord traction, but it should only be done if the skilled birth attendant is present. And fourth component is the immediately assessment of the uterine tone, which should be done at every 15 minutes for 2 hours.
So what is important to note is that WHO has changed these guidelines in the year 2012. Initially, we used to recommend control cord traction for all deliveries. Now it is no more recommended. The only essential component that is recommended is administration of oxytocin. Rest all is an optional treatment. So that is very important for all the postgraduates to know. And control cord traction is only to be done either in cesarean deliveries, in vaginal deliveries, only if a skilled birth attendant is present. And no bimanual massage. Like I am emphasizing, because you said in your algorithm bimanual massage, that is for the treatment of PPH.
Yes,
When we are talking about the prophylaxis, bimanual massage is not recommended. It is neither uterine massage is recommended. So no kind of massage is recommended. It's only the assessment of the tone that is recommended. So that is very, very important for all the postgraduate not to get that wrong. You know, that the active management is not typically that we used to study 10 years back. So it has changed.
You had very beautifully explained the implementation of the uterotonics. They say if there is a presence of skilled health personnel at the site of delivery, then we should prefer oxytocin if it is available and at sufficient quality. But if it is not, if the skilled birth attendants are not present, then lay workers can give misoprostol per orally 400 to 600 micrograms. And if the oxytocin quality cannot be assured, or if they are not available, then other uterotonics can be given by the skilled birth attendants, like arbitocin, which is heat stable, ergometrin, and symptometrin, and misoprostol.
So misoprostol, you know, nowadays everybody should know that misoprostol is available with the ASHAs. And, you know, the government of India is promoting that because it is heat stable. It doesn't need any refrigeration. It has got low cost. So it is cheap, effective. So it is there in the bags of all the ASHA workers as well. So even for peripheral deliveries, it is recommended that misoprostol can be administered for the prevention of, for the prevention of PPH if nothing else is available.
If your trained workers are not following the CCT, what do they do? How do they deliver the placenta?
And they will wait for the spontaneous expulsion of the placenta.
That is the expectant management.
Expected management.
What are the signs of placental separation?
Ma'am, foremost sign is the gush of blood. Then there is a lengthening of the cord. We will see the placenta at the vagina, and there will be a
suprapubic bulge.
Suprapubic bulge will be there.
And lengthening of cord will be permanent.
True lengthening of the cord. So, should we continue with hemostasis now? So, first step in hemostasis is call for help. So, how many personnel do you need to help in your PPH?
Ma'am, at least 4 persons are required, and ma'am, 1 senior obstetrician to be also called. H in hemostasis stands for call for help. We also need to send alert call to some other departments like hematology lab, blood bank, OT staff, anesthesiologist, ICU and interventional radiologist if available.
Okay.
This
Next
is
step
the
is
image of hands-on uterus, how to give uterine fundal massage.
you have called for help now. What do you do next?
Ma'am, after then, ma'am, we have to assess vitals, blood loss estimation, and we have to start resuscitation, which depicts A in hemostasis. Assessment of vitals.
You assess for the vaginal bleeding as well as you assess for the hemodynamic status of your patient. Both. For hemodynamic, you are taking pulse, BP, oxygen saturation, and respiratory rate. How do you do the blood loss estimation?
Ma'am, for blood loss estimation, various methods are available. I have followed during our delivery was visual estimation of blood loss. This kind of pictorial diagram is available, which can be pasted in our labor room, which helps in our estimation. This whole
it is there in our labor room.
Yes, it is there, ma'am. This full kidney tray depicts 500 ml blood loss. The soakage of pads depicts half soakage depicts partially soakage depicts 30 ml and full soakage depicts 100 ml. This
method is it a very accurate method?
No, ma'am. This usually overestimates or underestimates around 30-40% of blood loss. Some accurate methods are available, like we can use under buttock blood collection drapes, which is there with the name of brass V drape. This is a calibrated plastic close-ended under buttock blood collection drape, which improves valid estimation of blood loss. As you can see, there is a calibration scale through which amount of blood loss can be assessed, and which will be
has a yellow and a red line. So yellow is an alert line, and when it fills till red line, it is more than 500. So you have to be alert at that time.
Yes,
but in this drape, blood can be mixed with your other secretions also. So
yes, ma'am. So again, ma'am, it may overestimate our blood loss estimation. We can also weigh our soaked swabs. There are some indirect
pre-delivery and post-delivery weighing of the swabs.
Yes. There are also some indirect measures available to assess blood loss. That is, obstetric shock index can be used and rule of 30. In obstetric shock index calculated as pulse rate divided by systolic BP. Its normal range is 0.7 to 0.9. If OSI is more than 0.9, it depicts need for blood transfusion. And rule of 30.
And in any case, it should not go more than 1.
More than 1.
That is the alert.
So the rule of the thumb, easy to remember. It's very difficult to remember. 0.7, 0.9. Simple सी बात है कि अगर आपकी pulse आपकी systolic BP से ऊपर चली गई, so that is something that is abnormal. So
yes,
just remember that your pulse should not be more than the pulse of your patient should not be more than the systolic BP of your patient. So if you remember, that's an easy way to remember. It should not be more than 1. If it is more than 1, there's definitely something abnormal.
This is rule of 30. Everything is around 30 in this. Fall in systolic BP by 30 mmHg, increase in heart rate by 30 beats per minute, respiratory rate rising more than 30, hematocrit falling less than 30%, and reduction in urine output, which is less than 30 ml per hour. If all criteria suggest that the woman has lost at least 30% of blood volume.
So one more thing here, that this rule of 30 can be applicable only if you know the baseline parameters of the patient.
Yes, ma'am.
If the patient has come to you with bleeding, you cannot assess this. There, a better index would be an obstetric shock index, because especially in like hypertensive patients, if they come to you with bleeding, they might have a BP of 120 by 80, but that BP for them may be a hypotension. So if her pulse is 140 and her BP is 120 by 80, that is abnormal because the pulse is 140. So this shock index is a very, very important thing, which all of us, I think, should incorporate in our clinical practice. It is not just for a theory class, but all of us should start using and applying this obstetric shock index for patients who ever come into the casualty. Okay.
Especially in PI patients which have a baseline high BP, you might not be able to assess the shock. Okay, now that how do you classify the blood loss?
Ma'am, Advanced trauma life support system has given classification for blood loss according, it has categorized into 4 categories. Class 1 says blood loss of 10 to 15%, in which 500 to 1000 ml of blood loss occurs. Here BP will remain normal, which will be more than 90 mmHg, and patient will complain of palpitation and lightheadedness. Class 2 categorizes if blood loss is 15 to 25% and it is 1000 to 1500 ml. Over here, BP will start falling and heart rate will start increasing. BP will be 80 to 90 mmHg. Heart rate will be 100 to 120 beats per minute. Respiratory rate will be 20 to 24 per minute. And patient will complain of weakness and sweating will be visible. Class 3 depicts if blood loss is 25 to 35%, which is 1500 to 200 ml of blood loss. Your BP will fall up to 70 to 18 mmHg. Heart rate will rise up to 120 to 140 per minute. The oliguria will occur in this stage. Patient will complain of restlessness. Patient will be confused and skin will be cold and clammy. Class 4 is a category of severe hemorrhage. Here, blood loss of massive hemorrhage. Blood loss of 35 to 45% means more than 2 liters of blood loss will occur. Your BP will fall up to 50 to 70 mmHg. Heart rate will rise more than 140. Anuria will be appreciated. Patient will be lethargic and even patient can collapse.
So your
So what do you
patient
think? That is exactly what I was going to ask, Dr. Bindu.
Okay.
Your patient was in which class?
Ma'am, my patient was in class 2.
What if she was in class 4? You found her in class 4. What would you do? Would your management change? Would your approach change?
Yes, ma'am. We will immediately go for hysterectomy.
Once
Not
your
wait for
patient,
any further management.
the important point to note here is that if only you can try these conservative measures, if the patient is in class 1 or class 2, once the patient slips into class 3 or class 4, and especially if she's a multigravida, there is, you have to remove the offending organ, because the more you wait, the more blood loss she will have and she might go into irreversible shock. So once she slips into this class 3, she starts having a fall in the urine output, the heart rate goes, touches 140. I think do not think much towards conservative, especially in your patient. I would not think twice. Even in class 3, I would not think I would go ahead with hysterectomy. Only yes, in class 1 and class 2, we may try. But, they go through these classes very quick. These classifications are very blur when we see them practically. What is the amount of blood loss that the patient might incur? What is the rate of blood loss in PPH?
Ma'am,
uterine blood flow, how much is it increased?
Ma'am, at term, uterine blood flow is
very fast.
750 ml per minute.
Can be around 600 to
it's 500 ml, not 50 ml. It is around 500 ml per minute. It's not 50 ml.
No, ma'am, I said 750.
750.
You said 750. Okay, sorry.
Yes,
It could go up to
50.
500 to 750. So she can lose very fast.
Yeah.
And Disha, you shifted your patient with bimanual uterine massage. So suppose your patient goes into class 4. Is there any other way you can,
yes,
while shifting your patient, any other maneuver you can do?
Yes, ma'am. I will prefer to give aortic compression.
Yes. You can give aortic compression while you are shifting your patient to OT. How do you give aortic compression?
Ma'am, I will place my fist just above the umbilicus towards little bit left side, and I will lean my whole body over the in that area vertically, and will press towards the spine, and will try to feel aorta in my under my knuckles.
Do you have a picture to show us?
Yes, ma'am. Just left towards the umbilicus, and after putting my leaning over this, I will check for femoral pulse. If I'm able to feel the pulse, my pressure is inadequate, and if pulse is not palpable, pressure is adequate.
Okay. And in your PPH, when you were mentioning the management of PPH, there were 3 people, right? One on the head end, one on the arm, and one on the perineum side. So what is the person on the head end doing? That is important. Most of us don't be at the head end. So
ma'am, person standing at the head side will start administering oxygen patient, if massive hemorrhage occurs, he has to check for airway, breathing, and circulation, and he will try to keep the patient warm.
And that person can give Arctic massage if needed.
Yes, ma'am.
And also that person will keep on talking to the patient. You know, it is important to monitor
Talk
the
to the patient.
sensorium of the patient. So once, you know, you need to know how alert and active your patient is. Sometimes you're just managing in the perineum and the patient collapses and you don't even know. It has actually practically happened. So the person as the head end checks the alertness of the patient, keeps asking the patient, keeps talking to the patient. That is also one very important thing. And what is the person on the arm end doing?
There are two doctors standing at the arm side, left and right. One standing at the side will keep on giving uterotonics, turn button as and when required. Another one standing will check for vitals and will manage rushing crystalloids until blood has arrived.
Okay. So
And he will also draw blood samples.
yes. So you
Which
put in a
cannula do
whiteboard.
you use? Which
Ma'am,
cannula do you use?
Large wide bore cannula, 14 or 16 gauge cannulas are preferred.
Do you remember the color of this cannula?
Yes, ma'am. 14 gauge is orange color and 16 gauge is gray colored cannula.
So you have to remember that in rush you won't don't try to see that it is 14 or 16. You should remember the color. Just pick up the color from the card and you can start the lines.
And they should be there in your PPH tray as
Kit,
well, because
yes.
normally you don't find gray cannulas. It's very difficult to find gray cannulas.
You
So
should
that
keep
should be
it
a part.
handy.
Yes, ma'am.
So what fluid therapy would you give? You know, obviously you have arranged blood and you will tell somebody to get blood. But before blood is getting ready, you need to give her something, right? So what will you give her?
Ma'am, I will start rushing fluid. Main thing, I have to make sure that the fluids which I'm infusing should be warm, as I don't want my patient to go in hypothermia. And the amount, how much blood has been lost, twice the amount I will give fluid to the patient. Maximum volume which is allowed is 3.5 liters of clear fluids can be given, of which 2 liters of isotonic crystalloids and 1.5 liters of colloids can be given. And the crystalloid of choice is RL and colloid of choice is succinylated gelatin.
And it should be warmed. You should,
Yes,
how do you warm a fluid?
We have a warmer in our ward. There is a
They're
warmer for
basically
water.
designated. Yeah, they're designated fluid warmers that
Fluid
are available.
warmers.
So all of you should know how to use those fluid warmer infusions, you know. So the fluid goes through that warmer thing and then goes to the patient. But why do we want to warm the fluid? Why don't we like that?
If patient goes in hypothermia, patient can end up in metabolic acidosis, and this will further take patient towards the shock.
Yeah, it aggravates DIC. So keeping the patient warm. So this is also one of the methods, you know, give warm fluids as well as keep the patient warm, you know,
Yes,
because the patient's self warmth may not be so much. So you might have to give her electric blankets, you know, if they are available, or maybe put in a heater. It's very important to keep the patient warm.
Yeah.
Otherwise, it's hypothermia can aggravate
Metabolic
shock
acidosis.
and the patient can go into aggravate metabolic acidosis and the patient can go into DIC. So what about blood? How much of blood you would give? Then what about blood components?
Yes, ma'am. About blood, I will give Paxel. I will rush 4 Paxel volume. If cross match blood is available and group specific blood is available, I will rush that. But if it is not available, I will start giving O negative blood group. Uncross match O negative blood can be given. About fresh frozen plasma, if PT, APTT, INR ratios reports are available, and if it is more than 1.5 and hemorrhage is ongoing, I will rely on that report and I will give about 15 ml per kg of FFP. And if FFP tests and results are not available, I will start giving 4 units of FFP after completion of 4 units of Paxil volume.
So usually we don't have INR reports coming so soon, you know, when you're having PPH. So
Yes,
once you've given, what is massive transfusion? What is massive blood transfusion?
Ma'am, massive transfusion protocol says that blood products to be transfused like exactly like what we have in our body, whole blood. So 1:1:1 ratio, we have to transfuse all the blood products.
And when is it triggered? When do you trigger the massive transfusion protocol? So the massive transfusion protocol, we call it when we are administering massive amounts of blood. Now, what is that massive amount? It has been defined if like you have replaced the whole volume of blood within 24 hours, or more than 50% of the blood volume has been replaced in 4 hours. All right. Or if you give arbitrarily, it is 6 or more units of blood. If you have given that, it kind of says that it is massive blood transfusion, that the patient has received massive blood transfusion. Although we, give it after 4 transfusions, only we start giving the components as 1:1:1. And what is once, the patient has lost so much blood and this massive transfusion protocol is activated, how long do you keep on giving blood and FFPs and platelets?
What is your target?
What is the target?
Ma'am, this is the guidance from the British Committee for Standards in Hematology. This therapeutic goals, we have to target these goals. Hemoglobin should be maintained at more than 8 grams per deciliter. Platelet count should be maintained at more than 50,000 per microliter. And this PT-APTT ratios should be less than 1.5 times in normal. And serum fibrinogen should be more than 2 grams per liter.
Okay. So that's okay. So you've given her blood and fluids and everything. What would you do next?
Ma'am, after resuscitation, ma'am, this is a simultaneous process.
Side by side, we will continue giving uterotonics to the patient. The first line agent is the oxytocin, which is to be started at 20 to 40 international units in 500 to 1000 ml of RL. It has a rapid onset with a duration of action 10 to 15 minutes. It should be avoided in patients with hypotension and SIADH. The most important side effect is the sudden hypotension, tachycardia, and arrhythmias with the IV bolus of the oxytocin. The second line uterotonic is methergine, which is an ergot alkaloid. The dose is 0.2 milligrams to be given intramuscularly. It can be repeated in every 2 to 4 hours. Maximum up to 5 doses can be given. The onset of action is 2 to 7 minutes with a duration of action of 2 to 4 hours. It is avoided in patients with hypertensive disorders, heart disease, peripheral vascular diseases, coronary cerebral artery diseases, and HIV patients who are on treatment with protease inhibitors. Common side effects are nausea and vomiting. Another second-line uterotonic is carboprost, which is a 15-methyl derivative of PGF2-alpha. The dose is 250 micrograms to be given intramuscularly. It can be repeated every 15 to 90 minutes, and maximum up to 8 doses can be given. The onset of action is 1 to 2 minutes, and the duration of action is 15 to 20 minutes. It is avoided in patients with asthma, pulmonary hypertension, renal, liver, and cardiac diseases. The common side effects seen are diarrhea, vomiting, fever, flushing, and tachycardia. Another drug is tablet misoprostol, which is a PGE1 analog. It is an add-on drug which is to be added with other uterotonics and never given alone. 800,000 microgram kept rectally or 800 mcg given sublingually. The onset of action is 3 to 5 minutes, and it can lead to rise in temperature and nausea, vomiting, and diarrhea.
So out of all these oxytocics, which would be your drug of choice?
Ma'am, oxytocin.
That is clear. But besides oxytocin, which is the drug that you would not like to use? Out of these drugs, there is one drug that I don't like to use, and most of the obstetricians don't like to use. Misoprostol. Misoprostol.
Ma'am, it is an add-on drug. It cannot be given alone in the management of PPH.
No, but is any carboprost? Have you ever used carboprost?
Yes, ma'am.
So it causes a lot of diarrhea and vomiting. That is a very pronounced side effect. And the patient is already losing blood, and there is more fluid loss that occurs with diarrhea and this vomiting. So it becomes very difficult to monitor this patient with an ongoing diarrhea and vomiting. Misoprostol does not have that much of side effect. Carboprost has and it is known to cause severe bronchospasm as well. So the side effect profile is out of all these is the worst for carboprost. You know that it can cause a really intractable diarrhea, which the diarrhea itself can make the patient go into hypertension. We have had a very bad experience. I don't know whether this has happened in Kasturba or not, but
Ma'am, even hyperpyrexia, confuses
Yes.
the treatment quite a lot. Like if patient has high grade fever, you are confused that why she's having because of the drug or there is something else. So it can be confusing.
Any other drug? Any other drug that
Yes,
you can
WHO has recommended the use of tranexamic acid in 2017. It is an antifibrinolytic drug. It can be given at a dose of 1 gram IV slowly over 10 minutes, and it can be repeated after 30 minutes if there is ongoing bleeding or if the bleeding reoccurs in 24 hours. Contraindication is any hypersensitivity reaction to Trenexa, and common side effects seen are nausea, headache, and diarrhea. The WHO says that early use of tranexamic acid, that is within 3 hours of birth, in addition to standard care, is recommended for women diagnosed with PPH. Beyond 3 years, it does not come for any clinical benefit.
Okay, now that you have given the uterotonics, you have replaced the blood, you have started the colloids, crystalloids also. Now, how do you establish the etiology in your patient? That why is she bleeding? What all factors do you check?
There are mainly 4 T's of the PPH: tone, trauma, tissue, and thrombosis. In the tone describes uterine atony, which can be due to over distension of uterus, uterine muscle exhaustion, functional or anatomical distortion of uterus, any intraamniotic infection or uterine relaxing medications.
Your patient was on any medication?
No, ma'am. In drug history, my patient was only taking iron and calcium tablets and were not on any chronic drug intake. After ruling out tone, the tissue describes retained tissues. There can be retained products of conceptions, retained blood clots, retained cotyledons of the placenta, or any abnormal placentation.
Okay.
In trauma, we will look for lower genital tract traumas like lacerations of cervix, vagina, perineum, periurethral lacerations. There can be extensions in the cesarean, and there are also possibility of uterine rupture or uterine inversion.
What's your fourth T?
And 4th T, thrombin, stands for abnormalities of coagulation. The patient can have hereditary coagulopathies or can have acquired coagulopathies like ITP, thrombocytopenia, PATMC, and DIC. Also, patient can be on any anticoagulant medications.
Okay, so you have to check for all the 4 T's quickly. You have to check for tone, you have to check for retained products, you have to look for trauma and
tone of the uterus and any coagulopathy. The S in hemostasis stands for shifting the patient to the OT. The patient can be shifted while maintaining
shifted to the OT or
or if the patient is present at a low resource setting, then we need to shift the patient immediately to tertiary center for further management. There are certain temporary measures to be followed, like if we want to shift the patient to OT, we will do bimanual uterine compression and external aortic artery compression.
That we have discussed earlier. Now you can, if you want to send your patient to a tertiary care center, then how do you shift your patient?
Patient should always be shifted to tertiary center after being wrapped in NASG. NASG stands for non-pneumatic anti-shock garments. These NASG has 6 segments. The main mechanism of NASG is to shunt the blood flow from the uterus to the other vital organs like lungs, heart, and brain. It causes 50% reduction in the blood loss. How to apply NASG? We will put the NASG beneath. We will put the NASG beneath the patient in such a way that the upper border of NASG lies at the level of lowest risk. The first segment is wrapped around the ankle. The second wrapped around the ankle simultaneously by 2 persons on both the sides. The second segment is wrapped around the calf, and third segment wrapped around the thighs. These 3 steps are to be done simultaneously on both the limbs. Then segment 4 is wrapped around the pelvis. Segment 5 is wrapped around the umbilicus with keeping a ball and center. And then the
NASG is closed using a Velcro by closing the 6th segment. At the end, we should ensure that the patient is breathing normally.
You suppose you received a patient with NASG in your center. So what all procedures you can perform with NASG?
NASG is made in such a way that it allows all the vaginal interventions and procedures. And also, if we want to do any emergency laparotomy in a patient, then 4th, 5th, and 6th segments can be removed and laparotomy can be performed.
And how do you remove NASG?
NASG removal begins at the ankle and we proceed slowly upwards, waiting 15 minutes between each segment, and we check vitals before removing each segment. It is to be removed only when the source of bleeding is treated and the women was hemodynamically stable for at least 2 hours. And blood loss should be less than 50 ml per hour.
Okay, now you have shifted your patient to the OT. Now you want to look for the trauma. If you quickly want to look for vaginal or cervical lacerations. So how do you look for cervical lacerations?
Ma'am, there is a cervical suturing set available in the OT, which contains 3 sponge holding forceps. First, we will retract the posterior wall of the vagina with the sim speculum. We will hold the anterior lip of the cervix at 12 o'clock position with a sponge holder. Then each quadrant of the cervix is to be explored by keeping the second sponge holder at 45 degrees. To be placed in between. And
you just keep on rotating your forceps and you spot the area where there is a cervical tear. And how do you stitch the cervical tear?
If there is a cervical tear which is not bleeding, then we can do wait and watch for the patient. But if the cervical tear is bleeding, then we will take the apex. We will take the knot 1 centimeter above the apex to include the retracted blood vessels, and then we will take interrupted sutures to repair the cervical tear.
Tresha, what if the apex is not visible?
Ma'am, then we will take a stay suture, and by causing a retraction, we will go upwards and close the apex upwards.
So you see whichever is the highest point that is visible, you take a suture, leave it long, just give a gentle traction because cervix is very, very friable. Give a just gentle traction, then place another suture 1 centimeter above it. Then make that second suture as the stay suture and just gently tug it and put a suture 1 centimeter above it. So that is how you can reach the apex even when it's not visualized. What if the tear is going till the vault?
Ma'am, if that is the case, then we have to go for emergency laparotomy.
Why?
Ma'am, because the tear can extend into the broad ligament, and there could be possibility of broad ligament hematoma or any retroperitoneal hematomas.
And any other thing that you can do if you are like, if it's a very high up till the fornix and you try to take it deep sutures blindly, is there something that you can do?
Urinary bladder and ureter is very closely placed structures and we can injure them.
So you do not have to take very deep sutures, especially when near the vaginal fornix. You have to be very careful that, ureter lies in close proximity. And if it is gone till the wall, there can be injuries up as well. So that calls for a laparotomy, right?
So now you have looked for the trauma and your patient doesn't have any cervical or vaginal lacerations. How do you proceed?
Ma'am, after trying uterotonics, if patient is still bleeding, we will try for tamponade. For that, balloon tamponade is done.
We have discussed tamponade, Bakri balloon. We have discussed what are the other kinds of.
Ma'am, there are different kinds of balloon available. We have follies also can be used for that. We can make condom catheter if no balloon is available in our setup. This is rush balloon, sense-taken Blackmore balloon can be used. This one is newer advanced Belfort Dildeep double balloon, in which there is another bulb which stays in vagina in case there is any vaginal bleeding And it also gives support to the balloon inside the uterine cavity. Like we don't have to do vaginal packing as we have to do in another one.
And with vaginal lacerations, you can use it as a tamponade there.
And ma'am, in India, this Chhattisgarh balloon is also made. We can also make the Chhattisgarh balloon. It is a modification of a condom catheter, which directly mimics a Bakri balloon.
Yeah, so I think this is beyond the scope of this webinar to go into the details of how it is made, but it's very simple to make a Chhattisgarh balloon, and it is a indigenous way, and there is a drainage port that you are creating. So all of you, all the postgraduates should know what is a Chhattisgarh balloon, and also Elavi balloon. What is an Elavi balloon?
Ma'am, this is Elavi balloon. Here, ma'am, there is a balloon at one side and there is a bag in which around 1000 ml of fluid is filled first. Then balloon is inserted inside the uterine cavity. Then this filled bag is hung at the height of 1.5 meter from the patient. This fluid will start spontaneously rush inside the balloon and it will be filled out up till the pressure allows inside the uterine cavity. And after that, ma'am, as in when uterus will contract, this fluid will again start rushing inside the bag. So this gives a visual indication about the uterine contractility and facilitates removal of balloon faster. And
it is an open system, you know, it is an open system where you are keeping the knob open so the fluid can go any ways according to the pressure desired. It can go from the container to the uterine balloon, or from the balloon, once the uterus contract, it can actually go back into the container. The only disadvantage of this is that, you know, it affects the mobility of the patient. Like when you put the catheter and the drainage here, it's like you will have to, you know, you'll have to close the knob. In case the patient has to move, then this knob has to be closed. So,
and it has 3 demarcations. If according to the patient's BP, if it is 80, 90 or 100, you have to increase or decrease the height of the bag.
Yes,
ma'am. It has 3 marks on the tubing. You can see the 3 marks. They are for the BP. You measure the BP. If it is 100, you stay at first mark. If it is 90, you go on higher because high volume of the fluid will be rushed. And if it is 80, you use the topmost mark. Okay, any other?
Ma'am, this is also one of the recent advances. This is Paniker's vacuum suction hemostatic device. Mechanism of this device is inserted inside the uterine cavity where these bigger balls are seen, and the smaller balls will stay at the cervical canal, and then this end is plugged with the negative pressure vacuum. Once the negative pressure is started, these balls will start sucking all the collected blood clots, and finally sinusoids and arterioles of the uterine cavity will be sucked inside the hole of this cannula, and mechanically this sinusoids and arterioles will be closed. So it controls bleeding this way.
Why there are small holes for the cervix?
So that, ma'am, cervix gets closed.
Yes. So the cervix is also sucked in and it is closed.
What
Okay,
else?
now,
Is there a Paley's clamp also?
Yes, ma'am. Ma'am, this is Dr. Paley's clamp. These clamps are used, it is basically a alternative to uterine artery ligation. So this clamp can be inserted transvaginally up to the paracervical. Through there, ma'am, we will try to clamp uterine arteries both the sides. And ma'am, transducer ultrasound can be used so that position of uterine arteries can be better located through that.
Is it a permanent method? Is it a treatment for PPH?
No, ma'am. Basically, this is a temporary method.
Yes. You cannot leave the clamp in situ, right? So what you do is, like, if this is the open cervix like this, you just open the clamp, put it at the side of the cervical lip like this, go deep, and then close it. so that, this end will be at the level of approximately the fornix, above the fornix, and it will clamp the uterines at this level, but it is just a temporary method. You should not be using it for quite a long time, because there is a possibility that once you're clamping the uterines, you will also clamp the ureters along with it.
Ureters also. And you
So
have
it
to
should
release
not-
the clamps intermittently.
Yes.
Once you put it, you simultaneously keep on relieving the clamps and then reapply if needed.
So it is just a temporary measure that all of us should know.
Now that you have tried the tamponade and your patient is still deteriorating,
So,
then
ma'am,
what will you do?
we should go for surgical method. Firstly, we can go with applying compression sutures over the uterus. Various methods are available. Among them, ma'am, the commonly used methods are, we can apply V-line sutures, Haemorrhage sutures, Chaw sutures, and Pereira sutures.
There are n number of sutures described these days, but these are most commonly used. Okay. How
Yes,
do you
ma'am.
take? How do you take? Just quickly describe, because we are running
Ma'am,
short of the time.
this is the image of V-line sutures. This kind of suturing, compression sutures are preferred in case of hysterectomy.
But do you compress? But do you actually compress with these sutures?
Ma'am, uterine cavity,
Uterine cavity in fundus of the uterus. Okay.
fundus of the
And
uterus.
you are using this Haemorrhage sutures also. Why do you prefer Haemorrhage over this? And in
Ma'am, Haemorrhage and Chaw sutures are preferred in case of vaginal delivery, because we don't need to do hysterectomy. Like in V-line suture, we need the uterine cavity to be opened. In Haemorrhage
if you
suture,
are doing a cesarean section and you want to apply, then you prefer Baleen suture. But if you are doing a laparotomy and there is no hysterectomy scar, you will go for Haemorrhage suture. Do you apply any other suture with the Haemorrhage?
ma'am, yes, ma'am.
Yes.
Horizontal sutures are also placed at cervicoischemic level. So that lower
Cervicoischemic sutures are also applied with Haemorrhage.
to compress lower segment of the uterus.
Which suture material do you use for this?
Ma'am, chromic catgut is used for applying compression sutures.
Okay.
You should
Is there
not be
any-
using a delayed absorbable suture. That is the take-home message. Please do not use Vicryl for putting a Baleen suture. That is not recommended at all. You should be using a rapidly absorbable suture like a catgut. Okay. You can use
Why-
Vicryl rapid if catgut is not available, but not Vicryl.
Why not delayed absorbable sutures?
Ma'am, it will cause necrosis. It can cause necrosis and
And
ma'am,
anything with gut adhesions or anything?
Bubble loop
Bowel
can
strangulation can
Uterus
also
तो involute हो जाएगा ना, वो suture ऐसे ही रह जाएगा.
अच्छा, ma'am, bowel can
Uterus will- yeah,
entangle.
so
bowel
bowel can
strangulation.
come
Bowel
inside.
can entangle in that, and bowel
Yes.
gangrene can occur.
Should I go for explanation of these sutures? I think it is going to take too much
Yeah.
of time.
I
We
think we
can,
are. I think we need to start winding off, Dr. Bindu.
Yes.
I think you can tell about the latest advances or the latest
Yes.
recommendations, and then we can wind off.
Yes.
Ma'am,
If just tell stepwise devascularization.
yes, ma'am. If compression method fail, we have to go for stepwise uterine devascularization, for which firstly we have to ligate bilaterally uterine arteries. Secondly, we can ligate utero-ovarian anastomosis. Thirdly, we can ligate anterior division of internal iliac artery. This is a
very time consuming, not done much. It is not at all time consuming.
Yes.
If you have the requisite amount of expertise, it just takes 5 minutes to
Yes.
do an internal iliac artery.
And it is very, very effective.
And you should start doing it on cesareans. One should practice it on cesareans, because in a panicky situation, you will never be able to just isolate it, or, maybe in your elective abdominal hysterectomies, all of you should push your consultants to show you the internal iliac, at least pass the suture through it, and then that should be it. But it's not at all difficult.
It has a 85 to 90% success rate if you tie the bilateral arteries. What does it do? I'll let you tie both the internal islets. What are you achieving by tying that?
ma'am, 40, ma'am, sorry, ma'am. question.
I mean, if you tie both the iliac arteries, how does the blood flow stops? What does it
Ma'am,
do?
basically, ma'am, we tie the arteries, ma'am, arterial pressure gets converted into the lower pressure, that is venous pressure. And because of that, ma'am, blood inside the vessel starts clotting. So
Because
bleeding gets
the
controlled.
high pressure arterial
High pressure gets
circulation
converted to low pressure.
converted into the low pressure venous system, and it helps in blood clotting. Okay. Then suppose you have tried everything, you have done this, you have done this, and your patient is still deteriorating.
Ma'am, last life-saving procedure, we have to go for hysterectomy. If
Total or
nothing
subtotal?
works, we have to go for hysterectomy.
Okay. Any other modality you can use?
Ma'am, yes, ma'am. Before surgical, even before entering into the surgical management, intervention, uterine artery embolization is the modality which is preferred. But drawback is this facility should be available at a setup and patient should be hemodynamically stable.
Because
Only
it
then we
requires
can perform.
fluoroscopy. So you should have a unit with fluoroscopy in your center. And this can be done in hemodynamically stable patients.
Hemodynamically stable patient.
And patients who are high risk for surgery, you know, that
Yes.
is good. Like I would just take, there was a patient of hepatic NCAF who had bleeding, and she had bleeding from the vagina. We could not understand. There was a small bleeder in the vagina, and we could not pick where the bleeder was. She was so friable, you know, we did explore her and she was just bleeding. She was soaking the pads. Her uterus was well contracted. We just could not know where the bleeding is coming. The more we explored her, the more she bled, you know, and then ultimately we sent her for uterine artery embolization, and we found that there was a small little spurter in the vagina that was bleeding. And the more, because her vagina was so fragile that when we were touching her, she was bleeding from all the sides. She was in DIC, you know, she was having a very bad, not in DIC, I mean, she was having a deranged coagulation profile because of the fulminant hepatic failure. But we could save the patient because of this uterine artery embolization. So this can be really life-saving in patients who are otherwise at high risk for surgery. We couldn't have opened her up to do an internal iliac artery ligation or anything.
And this is a very good procedure if you're doing it prophylactically in your patients who have a pus and the patients of pus. You already know that placenta is low-lying or accreta, then you can go for uterine artery embolization, because that is the only modality to save the uterus at that time. Otherwise, you have to resort to hysterectomy. So what all precautions do you take during hysterectomy? Total or subtotal?
Ma'am, subtotal hysterectomy is the procedure of choice, but in some cases, like if there is a cervical tear which could not be repaired, in case of some large fibroid lying over the lower uterine segment,
Uterine rupture, if there is a uterine rupture,
we have to go for total hysterectomy.
And especially in placenta previa, you know, it is said that if you do a subtotal hysterectomy, you might be leaving some bleeder, you know, in the lower segment, which is going into the cervix. And these patients are at high risk to have secondary hemorrhage. So even in patients with placenta previa or accreta, please try and do a total hysterectomy, because the incidences of secondary hemorrhage is very high in these patients.
So now you, suppose you have tried everything, you have tried uterotonics, you have seen for trauma, and your patient is still deteriorating. You have not opened up your patient, but her pulse is rising, her BP is falling, and uterus is well contracted. There is no trauma. You have checked for the trauma. But all will you look for?
And we can suspect any supralevator hematoma or the complicated ball ligament hematomas, intraperitoneal hematomas,
Uterine rupture.
and uterine rupture.
Intraperitoneal bleed also. In that case, what do you do in that case?
And if the patient is deteriorating and is unstable, then we will go for emergency laparotomy.
And if you go for emergency laparotomy, you don't find any bleeder. You know, you've done an emergency laparotomy more often than
it happens. Yes,
it happens most of the time. You don't find a bleeder. What do? You do a lavage and come out, or you do something?
Ma'am, we will do. total hysterectomy in this patient.
No.
So why would you do?
Ma'am,
अभी
there
तो
could
क्या
be
internal, हाँ,
Internal iliac artery
iliac
ligation.
ligation.
Do an internal
Even if
iliac
you-
artery ligation in the pelvis, whatever, wherever the bleeding is coming from, it's going to reduce the bleeding. You know, most of the times, even for post-cesarean hemoperitoneum, when we do a re-exploration, we never find the bleeder. So we just do an internal iliac and come out and put in a drain and come out and the patient stays okay. So that is what you're supposed to do.
So now your patient is managed, but all complications she can have.
I think we quickly wind off now.
Just
PPH can lead to the anemia, and it can also multiple blood transfusions are there, so there could be any blood transfusion reactions. The patient can have dilutional coagulopathy, and also there can the anterior pituitary ischemia occurs due to PPH, and this patient has syndrome, and postpartum depression also occur in patient with PPH.
I think we will wind up. Now this, you want to discharge this patient. Do you give any advice on discharge?
And at the time of discharge, we will repeat all the blood investigations. The IV iron supplementation is started to replace all the iron that is caused.
You can give IV iron supplementation at the time
IV or
of discharge.
tablet.
IV or oral. But
Tablet.
yes, you should give adequate antibiotics. You should check for lactation, and you always warn the patient regarding the secondary hemorrhage. Dr. Swati was asking in the beginning that what is the cause of secondary hemorrhage. So patients who have primary hemorrhage, they are very yes, that is secondary hemorrhage. Okay, so
And
you
do
warn the
not-
patient.
Do not discharge her without a contraception. She's
Contraceptive.
already had 4 children. I mean, and she has had a PPH. If possible, you know, if you're opening up the patient, do a ligation, take a consent and do a ligation. She should
Ligation.
not be having any further children. Anyway, she's anemic. So that is one important advice that must be given to this patient. And in fact, you should ensure that if she's not accepting anything, give her centrochrome tablets and tell her to come after 6 weeks for a ligation. So that is what you can do.
So good evening, Dr. Achla.
Good evening.
Good evening, ma'am. Good evening.
Good evening, ma'am.
Yeah, I've been listening halfway through because there was a AOGD meeting. So I don't know what all was covered, but I will just take 5 minutes to tell practically, you know, maybe it has been covered or not covered. I'll just say that PPH, of course, we all talked about an emergency. So whenever you go to labor room, assess all the patient, classify them into whatever risk they have for PPH, arrange blood for them, and then look at your PPH tray before you start your rounds. And then PPH is occurring, it is not, you know, one step after the other. When you're doing one step, your mind should be very alert, what I'm going to do next, and make preparation for that. It's not that this is over, then you tell. Suppose you want to do a tamponade. While you are, you know, doing your medical management, one after the other, same time, tell somebody to prepare, because after you have done the medical management, then you ask somebody to prepare. So when you are doing medical, one thing I wanted to say was that methadone and prostaglandin, it is written you can get up to 7 and methadone up to 5. But if your patient does not respond to 2 methadone, don't keep on giving. Or she doesn't respond to 1 prostaglandin, don't keep on giving. 7 doesn't mean that you keep on giving if she's not responding. And then when you, like, one thing I said is keep next step in mind. That is very important. And then when you're taking patient for surgery, always never put the patient in supine position. You will not be able to see what bleeding is occurring. So when you take a patient for laparotomy for PPH, you should be in that modified lithotomy position, which you have for laparoscopy, so that you can work abdominally and also you can see what is happening vaginally. Otherwise, you'll be, you know, removing the sheets all the time to see how much bleeding is there. So that is very important in case of PPH when you're doing a laparotomy. And of course, I think most of the things have been covered, but just wanted to emphasize that your thinking process has to be tuned. That's why you must keep doing drills that after this has to be done. So the other person should be ready with the next step and not you finish one step, then you ask for the next step. So that is most important. Otherwise, I think you people have covered it extensively.
Dr. Achla, Dr. Seema, you would like to say, add on something?
Yeah, good evening, everyone. Good, and thank you, Dr. Achla, Dr. Shivani, Dr. Sangita ma'am, for having such a wonderful class. And Dr. Bindu and Dr. Swati has really done their job very beautifully. And I think nothing is left in PPH management, and they have covered all the medical and surgical management very beautifully. And the attendance was also very good today.
And one more thing I wanted to add was that, like when we are talking of component therapy, you have to see the cause of bleeding. If your bleeding is occurring because of abruptio, then you have to be ready with the components along with blood, because the reports wouldn't come. But if it is because of, say, just atony, then you can give blood and wait. But if it is because of abruptio, when there's a high chance of that she can have DIC, you should simultaneously arrange blood and FFP together. I think you do also, but for the PGs to know that you have to know the cause. If it is DIC prone cause, then arrange simultaneously. Otherwise, you can give 2 bloods and see later if more is required, then you arrange the other components.
Thank you, ma'am.
One more thing here I would like to add, that most of the patients, they don't come with only one diagnosis. There are multiple like complications can be there. So we should keep in mind the patient as a whole, like the complete diagnosis should be known, and we should try as early as possible to make a complete diagnosis and to treat the patient as a whole. So that nothing is left, and later on we don't come like, it does not come as a surprise to us that this complication is also there. So it's better to diagnose earlier and treat early so that complication rate is less.
Thank you, Dr. Seema, for the
Thank
inputs. Dr. Sangita, is she there? Dr. Sangita?
Yes, yes. Take-home message should be for the PGs that once you face a PPH, you raise alarm, ask for help, don't panic, use your rationale and manage effectively as discussed in detail in today's session. So we measure the capability of a resident by how efficiently she has managed the PPH.
Dr.
That we all
Sangita,
do.
a few words for our PGs. I think they have done a good job. So please.
Excellent, excellent. They have done very good. I never expected they will speak so well, but to keep it up.
They were very good, ma'am. You should be proud of your PGs. Disha
Yeah,
and Shreshtha, both of
Yeah,
them were,
both have done well.
they were very good. They answered beautifully.
Yes, and you moderated very well.
Thank
Dr.
you.
Yeah.
Swati and Dr. Bindu.
So
Dr.
on
Bindu,
behalf of AOGD and the Delhi PG Forum, I would like to thank the new team of AOGD. Despite the important executive meeting, Dr. Abha and Dr. Seema took out time to attend this forum. And luckily, this was our hospital presenting this time. I would also like to thank the chairpersons, Dr. Sangita and Dr. Achla, for valuable inputs. And Dr. Sangita, I must say that in spite of her busy schedule, she spent today, I think, quite a lot of time with the PGs to see to it that everything goes right. And Dr. Achla ma'am also, in spite of her meeting, she gave her valuable inputs. So we are really thankful to her. And our moderators, Dr. Bindu and Dr. Swati, have really toiled hard with the postgraduates to give this nice performance today. And of course, our PGs, Dr. Disha and Dr. Shreshtha, I think I am not the right person to say. I think the externals should say that they have really,
yes,
really
they have really prepared the topic very well. And
Yes.
the moderators have really asked the typical questions like which every PG should know. So
Yeah,
that
thank
was
you,
really
Dr. Seema.
All the credit
Thank
goes to
you,
Dr.
Dr.
Bindu.
Seema, for
Yes.
I
And
must
Dr.
say
Swati.
I was merely a bystander. All the
No,
preparation was
Dr.
done by Dr. Bindu, and I just gave
really I appreciate
No,
that.
Dr. Swati, you very, very helpful. Don't
You
say
both
that.
were really good.
You were
Uh,
very helpful in that.
So,
Thanks a lot.
and I
Thank you.
also thank
It was enjoyable overall. It was nice.
Dr.
Thank you,
Deepika
Dr.
from
Sangita.
Jagsonpal for giving us this lovely platform, and also our viewers. You know, they have no questions. See, you have performed so well that they have no questions to ask. So I think that is one point that is very important. And so I thank the viewers. They must have really benefited from this class. So thank you so much, all of you.
I
Thank
think
you.
you must
Thank you, ma'am. Thank you. Thank you, ma'am.
thank
Thank you.
Shivani
Thanks,
also
everyone.
for her hard work. You know, every
Yes.
month after month she is doing it.
Yes, ma'am.
Thank you
And
so
Ma'am
much.
is a
Shivani is
rock
so
star.
deeply involved in all this.
And thank you, Dr. Shivani, for giving this opportunity to us.
Thank
To
you so
Kasturba
much.
Hospital, our PGs and
You
our
will get
PGs.
many
Thank
more.
you.
You did very well.
I will be looking forward to that. Thank you.
Thank you so much.
Thank you, everyone. And
Thank
good
you
night.
very much. On behalf of Jagsonpal, I thank the experts and the attendees and the PGs for this wonderful class. Jagsonpal presents Jepitone syrup. Say no to anemia. Bring back the colors of joy with Jepitone. For freedom from menstrual irregularities, we have CycloReg CR10, 10 mg tablets of norethistron controlled release. And Divatrone, fully indigenized micronized dydrogesterone from Jagsonpal, Divatrone 10 mg tablets. Looking forward to having more and more attendees. Please do join us for the next program, which is webinar ID is mentioned here, which can be taken down from the Facebook link also. This is on Saturday, 22nd April. And we look forward to having you all with us again. Thank you.